So, most of the diseases, whatever they are, infectious, tumoral, inflammatory, respond more or less to this kind of triad of three phenomena. First, either inflammation, giving rise to autoimmunity and or rejection of graft, promote active immunization, activation of the immune system. And usually, inflammatory autoimmunity are easily targeted by immunosuppressive anti-inflammatory drugs, but we agree that these drugs are not sufficient and not capable to control optimally the different degrees of inflammation and immune activation. This immunity, this immune activation, this inflammation is almost obligatory associated to some level of replication induced by infectious agents and or proliferation induced by tumors. Although in the case of proliferation, there might be a lack of inflammation and a limitation of the activation of the immune system. In any case, these replicative or proliferating diseases are usually relatively easily for infectious disease or problematically for tumoral disease targeted by chemotherapies. But in many cases, these chemotherapies, even if extremely potent, are unable to completely eliminate the disease. And we are faced with a residual disease, either infectious or tumoral, which is the most difficult target in the field of therapeutic strategies. So, here I'm proposing three avenues of applications for immunotherapies. Either specific immune interventions can target the infectious diseases or some tumoral antigens and help targeting better, more efficiently, the replicating or the proliferating diseases. In another field, immunotherapy is now extremely boosted, as you know, by the growth, the exponential growth of therapeutic monoclonal antibodies that can target any of the immune system molecules and help targeting much more efficiently and much more specifically the different mechanisms of inflammation, autoimmunity, rejection than the classical anti-inflammatory drugs. So two strategies for application of the immune-based intervention. But in all cases, these two avenues of applications, I think, have to be associated with the persistence of chemotherapies or of anti-inflammatory drugs. The key point, as I said before, is to target the residual disease, which is more than often persisting despite the most potent chemotherapies that can be used. And again, this is a field of application for immunotherapies. And again, with the exponential growth of monoclonal antibodies, we have certainly different modalities of application, either targeting the surface of the cells or even targeting intramolecular cells. And these immunotherapies might again complement the more classical chemotherapies which are proposed nowadays to target the epigenetic regulation. I'd like to show you one application in the field on which I am researching, HIV. And you might be aware that with the extraordinary progress of antiretroviral therapy, most of the patients now live with a fully controlled virus. But unfortunately, these antiretroviral drugs are unable to eradicate the virus, and we have to face the problem of the residual disease, as I mentioned before. So the new area of research, which has been launched by Françoise Barré-Sinoussi, the Nobel Prize, is to try to find a way to eliminate this residual disease and to find a cure for HIV. To find a cure for HIV, it is proposed a synergistic approach in combination with antiretroviral therapy, and to use either anti-latency agents that will reactivate the virus production in the quiescent cells which have harbored the virus, and or to use therapeutic vaccines or passive transfers of monoclonal antibodies to target the cells that have been promoted to produce HIV and to block their capacity to infect naive cells. But optimally, in the now classical shock and kill strategy, the idea is to add both anti-latency agents here, therapeutic vaccines or antibodies here, and to complement these two actions with antiretroviral therapy in order to try purging the reservoir. Where are we in this quest for an HIV cure? Not that far. In fact, the first trials, and we have been conducting 2 trials recently using either IL-7 as an immunotherapy to target the latently infected cells, or the VRC vaccine that were kindly provided by Gary Nabel, and unfortunately none of these trials provided any efficacy. And we have now to try to decipher which are the best candidates, perhaps among the immunotherapeutic tools, that would be the most efficient and the more tolerated strategies. To finish briefly, I'd like to propose another field of application, still in the domain of the infectious diseases. You are all aware that influenza is an infectious disease which is easily combated by vaccines inducing antibodies. But we know, and we had to face during the H1N1 pandemics, even if heavily debated, that some cases can be extremely severe and can lead to death. This death is not only associated with pandemic viruses, it can occur with seasonal viruses. So do we need an immunotherapy in this context? We have shown, in the context of the H1N1 pandemics, in the most severe cases that were observed in France, and particularly in my hospital, that the patients who died were completely deprived of antibodies against the flu. In other words, we can hypothesize that if those individuals would have been vaccinated, they would not have developed this very severe disease because their antibodies would have been here. But an avenue of research for an application for potential immunotherapy in the future might be to use broadly neutralizing antibodies against the flu and treat these individuals with these therapeutic individuals to restore high levels of antibodies and prevent death, which is an extremely important goal, as you might agree. So I will stop here with these proposals for applications of immunotherapies, and I leave the discussion.